Hello everyone, my name is Dr. Yashwanth. I would like to discuss about the zygomatic implant. The contents of my seminar presentation or the presentation include indication, introduction, history, zygoma implant, indications, contraindication, pre-surgical evaluation, surgical protocol. The contents include also prosthetic guidelines, complication, conclusion, references. Per Ingvar Brainmark is the first person to introduced endorsed implants as well as the zygomatic implants. So the conditions or the for which zygomatic implants are needed are resolved edentulous maxilla and pneumatized sinus. An historic perspective include Leaford-1 osteotomy, iliac bone graft, sinus lift procedures, bone grafting, tissue supported over dentures. Next, in 1998, Brainmark used has 95% of success rate in 110 patients. 97, Wischer et al. Has used titanium for the implants in zygomatic for hemimaxillectomy cases. So, the zygoma implant is an extended length implant or titanium fixture that is placed through crystal slightly parietal aspect of the reserved posterior maxilla tangentially into the compact bone of the zygoma. Anatomy is the zygomatic bone is present in the midfacial region. The mediolateral dimensions are 7.6 mm and 8 mm. Anteroposterior dimensions are 7 mm and 24.9 mm. Lateral cortical thickness include 1.75 mm into 1.71 mm. In the length and the length is 16.5 mm and we have 14 mm. Next, the stability of the zygomatic implant depends on ridge crest, sinus floor, roof of the maxillary sinus, and superior border of the zygoma. And the indications for the zygomatic implants are moderate to severe atrophy of maxilla, posterior bone grafting procedures, sinus extensions, syndromic patients, acquired and congenital defects, immediate loading, and partial edentulism. Contraindications include systemic compromise, sinus diseases, adequate bone for conventional implants, and reduced premaxillary support for stable implants. The pre-surgical evaluation includes clinical and radiographic. That is, first one should be acceptable soft tissue should be present, available bone present in zeno, that is pre-maxilla, cuspid zones and molar zones. Disease-free sinus, physically and mentally good health of the patient should be there, and patient is able to tolerate general anesthesia and deep sedations. There are three zones are present. That is, zone one include the premaxilla, zone two include bicuspids, and zone 3 includes the molar region. And radiological include sinus pathology and osseous anatomy of maxilla and zygoma should be good. Quality of quantity bone should be good with the radiological diagnosis made from OPG, CT and cephalometrics. And this is in CT showing the sinus health here, hemosinus is present and sinusitis is also present. And this is in CT showing the placed zygomatic implants. Next is surgical protocol. In this, IV sedation or general anesthesia, local anesthesia can be used. Trajectory of implant and implant size. The armamented here used as zygomatic retractor, which also includes the following burrs and also zygomatic implant, implant length check and gauge checker. And the Rilchan implant can be by following sizes, that is can be for 35 mm to 45 mm, and trajectory of implant should be of main importance here. So the trajectory is the implant should always land up in the zygomatic area, not in the infarctal region or the maxillary sinus region. This is a picture showing the placement of implant from parietal region into the maxillary sinus region. The red mark includes the placed zygoma implant, that is, it is placed into the zygomatic bone, actually not in the maxillary sinus region or not in the infarctal region. Next, coming to surgical procedure, it includes uh, clavicular incision followed by the palatal flap elevation, and uh, next we should make a window in the maxillary sinus region, followed by the checking the length of the made hole. Next is followed by placement of the zygomatic implant, and there should be a distance between maxillary sinus and the placed implant region. Next followed by the checking of the implant length by using any exercise techniques and seeing the implant from the made surgical window. Next followed by the insertion of the cover screw and place and suturing of the implant. Next for prosthetic face care is started. Next is the latest technique is the zygomatic anatomy guided approach. It is first uh, done by Carlos Aparicio in 2011. Here is a zygomatic approach and buttress and alveolar complex. Here is, there are five types, that is Zaga 0 to Zaga 4. Then the Jaga 0 is placed, the implant is mostly towards the sinus, and Jaga 4 is implant which is away from the sinus. And these are the clinical pictures showing the Zaga 0 to Zaga 5. And it is a quad zygoma. It includes the two zygoma placed on one quadrant and two zygoma in the other quadrant, followed by denture placement. Here these are the following types, which is followed by placement of an hybrid CD with the help of a rod. And next is the post-operative care. And the post-operative care includes soft diet, post-op medication, mouth rinses, occlusion, and follow-up. In prosthetic phase, the first phase is the healing phase, followed by splinting and final prosthesis. Here you can see in the healing phase, a wood pins are placed, followed by impression taking, and a rod is fixed with and to all to the gingiva, and final process can be given supported by implant denture. Here you can see an OPG showing the zygoma implants, followed by placement of endosseous implant in the anterior region, which are connected by a rod, and the next followed by the complications. It includes foreign body, then failure to osseointegration between bone and the body, and presence of any fistulas, periimplantitis, and oroantral fistulas. Next can be nerve deficit, malar emphysema, and nasal bleeding can also be seen. And the rarest of is the orbital injury. Here, these are the following studies. Here you can see that majority of the cases have bruising, sinusitis, and paresthesias, followed by labral lacerations. Okay, the least common one is the local infection. Only one study has more of the local infection. Here is a case report showing the oroantral fistula case, and in picture you can see that there is no osseointegration of the implant, and followed by the closure of the oroantral fistula. Here you can see the implant is disintegrated and it is attached to only the gingiva case. And the advantages of zygomatic implants are donor side morbidity is reduced or eliminated, treatment time is reduced, bone graft survival and consolidation are not considerations. The total number of implants to support was reduced. The treatment is more affordable and less invasive than other treatments. Disadvantages include should be done by only table tennis surgeons. Risk of agents such as like orbit orbital contains facial nerve. Postoperative sinusitis can be seen, and it will be less with sinus lift procedures, and fixture failure is rare. Conclusion.